Let me begin by saying something about Dr. Breman's career, because we're incredibly lucky to have him here with us. So his global health career began in Guinea, Burkina Faso, and other countries in francophone West Africa. He battled smallpox and measles as a physician-epidemiologist, working for the Centers for Disease Control, and he's focused on understanding, controlling, and eradicating smallpox, malaria, Ebola, Guinea worm, and other infectious diseases, working in villages at the end of the road, or as he says, where there is no road. Now, he has affiliations with the CDC, with the World Health Organization, with the National Institutes of Health, with the World Bank, and with governments and civil society in low and middle income countries, primarily in Africa, but around the world. And let me say something else about Dr. Breman, which is not part of his official bio. He's a USC grad. Oh. Whoa, whoa. And you can see the tie, right? So here we go. So he got his medical degree at the Keck School of Medicine, and he has been a longtime friend of this university. And would you all please join me in welcoming Dr. Breman? And let's hold questions till the end, okay? Great.
I'm so delighted to be here. As a professor mentioned, I graduated from the SC Medical School. At that time, it wasn't called the Keck School. But anyway, I did an internal residency program there because I was prepared to open up practice on Wilshire Boulevard or Park Avenue in New York or K Street in Washington, D.C., where we now live and have lived for 20 years since I returned to the U.S. But living in Washington, D.C. is also a strange and exotic place. It's a place where Henry Kissinger said the behavior of 90% of the people ruins the reputation of the other 10%. And if you watch TV, the hearings today, you'll understand that a little better. Very unusual. But let me first ask, how many are undergraduates here? Okay, maybe half the group. I'm delighted that we have undergraduates, and the rest of you are either professors or graduate students to be professors or to do international work. So I was a internal medicine resident, had spent internship there, and as you know, the county has indigent patients, and I loved the work there because I learned so much at that time, and now it's one of the best places in the world to practice and to learn about medicine, not just from the more richer countries, but also we have a lot of immigrant populations, a lot of poor populations. And so what I learned at the county was very helpful overseas. I delivered babies in the villages overseas too, because I had done a lot of that here at the county. But at the end of a year or so, I looked at my intern's book, which I still have, and my residence supervisory role, and I saw one condition that was related to most other things that I was dealing with at the county hospital or any county hospital in our country. Who wants to guess what that might be? Have been, and still is a problem. Smallpox? Yeah. In our country, no. That's a great answer, but yeah. Diabetes? Big problem, but it was and is a social problem.
Poverty.
Poverty related, it was demon rum, alcohol, an addiction. So I said, well, those patients, they affect every aspect, mental, social, physical, of course, neurologic. But I said there must be another part of medicine that I would like to see. And so I went to my professor of pediatrics, and I love pediatrics. I said, is there an opportunity to go to another part of the world to see the health issues there? And Professor Paul Wehrle, the chairman of pediatrics, introduced Vicky, who I met at the medical school. The program was the smallpox eradication program that the Centers for Disease Control and Eradication was now taking up in West and Central Africa. So let's move on here, Will. Now, the reason that we could take on this program, I'm going to speak on several diseases, mainly on the unexpected part, which in your life, in whatever career you take, the surprises will come at you unexpectedly. And as opportunists in your life, you will learn and benefit from them. So smallpox, we were able, this is part of the global program to eliminate this horrible disease. And the US, under President Lyndon Johnson's approval and support in 1965, had said, let's take on the hardest part. And West Africa, for a number of reasons, was what the CDC was assigned to do. We had had some experience there. And we took on 20 countries in West and Central Africa. And so my professor of pediatrics introduced me to the Centers for Disease Control. Quite frankly, I had never seen smallpox, never heard of the CDC, had never been to West Africa, and they accepted us to go to Guinea, a francophone country. Didn't speak French at all. You know, so it was totally unqualified, except, and we took on the countries mainly with a vaccine that had first been found, the early phases, by Edward Jenner. Anyone hear of Edward Jenner before? Anyone know? We have some scientists from the medical school here. Dr. Jenner was a country physician in England who found that cows had a pustular disease on their belly, and that pus, when inoculated into people, could protect what Shakespeare called, you know, the pox upon us, and this devastating disease that created scarring, debilitation, and death in virtually everyone who got this respiratory disease. In populations were very close, except the milkmaids, the fair skin of the milkmaids, which you will read in poetry and prose. So Jenner found that this vaccine, which was really mixed up with bacteria and was not stable, but it worked. So that was the source. Over the years, this was now in the late 1700s, vaccine wasn't perfected, but improved over the years. But almost 200 years later, we still had massive epidemics. Next slide. And West Africa, as you can see, had the top 5 countries in rates of disease in the world. And several other countries were among the top 12. So I was assigned to the West African country of Guinea, in the hump of West Africa, where I lived for 4 years. When we started as a pure vaccination program, the World Health Organization, which was trying to do stuff elsewhere, said, vaccinate 90% of the people and the disease will melt and dissipate and will eliminate smallpox from the world. So we spent 2 years there. And then after some more training, I spent 4 years in what was then called Upper Volta, just east, a landlocked country, still working on smallpox, but now my terrain was 8 francophone countries to follow on the smallpox activities, and we had measles also, because measles is a devastating disease, particularly in the poor, malnourished countries. And next slide. And get off the plane effectively, and within a few months, I saw my first patients with smallpox. Here they are. This girl, young woman, has these horrible pustules coming from the inside out after a 2-week incubation period. And she has this basically mud mixed with different types of natural products. And this is all that populations throughout the world had before they got access to vaccines and public health. And still today, a lot of people treat with traditional products the disease. So that's what it was. Local, these villages and communities use traditional medicines. And this, of course, has no benefit. This woman on the right I saw has one of the most severe types. There are several types of smallpox that you'll see. So her entire skin is like alligator skin. The virus, it's a virus disease, is just teeming in the skin and in the internal organs. She died the day after. There's nothing you can do afterwards. Up until actually last year, there was no drug to treat smallpox. It was only preventive work. So next, let's learn. So the first thing was unexpected. That is that the vaccination strategy of just vaccinating 100% of the population, or 90%, whatever your goal was, didn't work. There was so much smallpox that you couldn't just follow everywhere and vaccinate everyone all the time with a birth cohort at that time of, maybe 6%. Every woman had, per 1,000, every woman having 6 to 9 children, of whom maybe half would survive under the conditions where there were other problems. And here is one of our workers in Nigeria where they effectively ran low, if not out, of vaccine. Dr. Faggy was a missionary doctor who was also with the CDC, and he found with a limited supply of vaccine, if you vaccinated the people around the patient and had concentric circles, what we call surveillance containment, that was more effective than just mass vaccination, even in areas where there was no disease. So this was revolutionary. This was unexpected. This was a major contribution. And here is again one of our workers in Guinea taking specimens, because you could see this young child had pustular disease, looked like smallpox, but other things looked like smallpox, chicken pox, drug reactions, insect bites, impetigo, and on and on. There are dozens of things, measles, that look like smallpox. So that was another innovation. We got low in disease frequency that we had to confirm every case. Because eradication, that was the goal, is no cases within the context of a surveillance system that could detect cases if they existed. Quite a challenge. My country in Guinea had 4 million people at that time. West Africa had 120 million, Nigeria having over half of those, but going to every person couldn't be done. So next. Here's another innovation that we didn't have. You saw Edward Jenner with basically a tip of a quill pen in which you scratched, scarred, sometimes damaged the arm or leg of the patient, causing an abscess. The vaccine wasn't stable. Here we have two innovations, stuff that we do here at SC. You have multiple innovation programs. Probably in the engineering department, these things come out, but elsewhere. The fellow on the left worked for the US Army, on your left, Aaron Ismack. He invented the Pharaoh jet injector. an automatic, it was initially used for the Army, which could inject the smallpox vaccine subcutaneously. And there was another nozzle to inject the measles vaccine, which we gave concurrently, intramuscularly. And you'd carry it around this rather bulky box, and it was hydraulic operated. You had a pedal, and you see the child up front screaming because he got both vaccines at the same time. Even more effective was the bifurcated needle. Can everyone see this on the right? This is one of the greatest inventions in public health and preventive medicine. This is an adaptation of a sewing needle in which you dip the needle into a tube of a reconstituted vaccine and then hit the arm until a little drop of blood comes 15 times. And you could teach anyone in 15 minutes to do this. And so these two things are some of the greatest inventions in application of a product. So next, let's move on. So let's look at the epidemic curve of smallpox. There are only data from the French. These countries I mentioned were part of the francophone West African zone. With epidemics every 5 to 7 years, because with the newborn cohorts, population would increase and the children were susceptible and the older people who weren't vaccinated were part of that. So we arrived in 1969 and 67. In January 1969, it was gone from Guinea and Senegal, which I also covered. And by 1971, all of these 20 countries no longer had smallpox. It was unbelievable. People didn't believe it. But the strategy, surveillance containment, thinking with your head, worked. So next, here, the strategy we used was then used in the Indian subcontinent, which was really the big area. India, which at that time may have had over 600 million people, the traditional stronghold of smallpox, Pakistan, Nepal, India, Bangladesh, every country used the strategy, and by 1975, gone in the Indian subcontinent, along with several steps to confirm this. Next. So you can see these maps, WHO map 67, and even many of the areas that are white here, there was disease. We found that maybe 5% of all the cases, in some places 1%, were ever reported, ever recorded. Nothing to do. No one could get there. But by 1970, you can see West Africa, except for Nigeria, which in 1971 had the last case gone. 1973, all countries in Africa except Ethiopia and Somalia was gone. And by 76, even in the India subcontinent, this is unbelievable that the strategy that was totally unexpected and untaught worked. So next. Now, how do you follow up on these things? Of course, the countries are interested in other things, and when we lived in West Africa, now covering 8 countries, a surveillance box containing material to collect specimens from suspect cases with smallpox. By that time, a new disease had arose, and I'll show you that in a second. But cholera had now entered Africa, and yellow fever, which is still devastating. So we developed this kit with instructions and specimen collection and distributed them to the health people who were there and would collect specimens. You couldn't be everywhere in these 120 million people. So the local people were doing the work. We just brought the resources and networks and a certain cachet. That's what organizations do. But people like yourself get the job done. Remember that. People and the front lines get the job done. Organizations only give the resources. They should, they shouldn't get the credit. The people at the front lines, the national. Next. So here is the last patient. I mentioned different types of smallpox. This is the most severe type, where 30% of all the people who got this disease would die, and 50% of the young children and old people whose immunity, and pregnant women whose immunity is compromised, died. So this young girl was the last patient with the most severe form of smallpox in an island in the Bay of Bengal in Bangladesh, Rahima Banu. She's more famous there than the prime minister because she was the last case. And here she is. I saw her. I was doing polio work in 2002, and I made an effort to find her. This little girl, that's her here with her little baby, but you can see her face is scarred. And the social implications, I can go into that. She couldn't find a husband. She ended up with the poorest rickshaw driver in the village, who was trying to get the money we were leaving for her. It didn't work out when you got these diseases. Next. So you're going to see the first and the last case of smallpox in the world. Next. Here is Pharaoh Ramses V from 1100 BC. He was unwrapped because we had some interest in finding out if smallpox existed in Egypt at that time. And this is Ali Mal-Malan, well known in public health, October 26, 1977. And Ali has a milder form. You've seen severe. And here you can see he recovered without much scarring. And he was a cook in Somalia, went on to work for the polio program, and has since died. So you are seeing the putative index first case and the last case of smallpox in the world. Remember that. It's not here. Next. So while we were doing all this work in what was then Zaire, the Democratic Republic of Congo, this patient appeared, really in the jungle. And of course we were worried because the basis of these eradication programs are that there's no non-human reservoir. No animal maintains this, and that we have an effective intervention. This patient had a human monkeypox. We didn't know that. We had to send it to the laboratory, 2 laboratories. Collaboration, partnerships. One collaborating laboratory was Moscow, the other at the Centers for Disease Control. Uh-oh, do we have a non-human reservoir? There hadn't been any smallpox there, that area, for 2 years. And it turned out to be human monkeypox, a related orthopox virus with some clinical differences, although it looks exactly like smallpox. But it is not highly transmissible from human to human. Undoubtedly a zoonosis. Which one? We think squirrels, but still more research to do. Totally unexpected. So I spent a fair amount of time looking into this. Several countries in West Africa had a few cases, but none as severe in terms of transmission as what you've seen. But remember that new disease, new science, and to this day, we still have research going on. I must say that last 2 years in Nigeria, after 39 years, they had 1 or 2 cases. They had now a huge outbreak of 120 cases and 7 deaths. We don't know what's going on. Undoubtedly, it's what we call an epizootic, something going on within the animal population. Let's move on. Next. So let me talk also why I'm showing you this. Next. In 2001, we had the terrorist attack in New York. Someone who has never heard of that, the terrorist 9/11, we've all We all know about that. But here on the right are envelopes with anthrax being delivered to Senator Leahy and newspaper reporter Tom Brokaw, etc., and others. And we started getting worried about whether our country is at peril from bioterrorism. Next. So why'd they contact me about this? Because smallpox, which was now only in 2 laboratories, I'm working on malaria. They said, we had some conferences, can smallpox be used as a bioterror agent? And our country was not prepared if we had an attack from not just anthrax, but several other agents. And that resulted in a new department in Health and Human Services on protecting against bioterrorism. The president accorded a fair amount of money to looking into if we had an attack, what could be done. But there were 2 other things. One, should we destroy the last few strains of smallpox virus? Because at the same time we were working on the program, we were decreasing laboratories that contain the virus. And let me ask here, how many people have been vaccinated against smallpox? No young person born since 1971 should have been vaccinated in the US unless they're in the military or working in a laboratory with pox viruses or at risk for other reasons. I'm sure none of you are a member of a rogue terrorist group. But anyway, so we're the world. In 1984, the World Health Organization recommended that we stop smallpox vaccination and we stop checking the border for vaccination certificates, not just for smallpox, but for other things, because it was worthless. And the vaccine, there are certain complications. If you had immunosuppression, renal transplant, or whatever, HIV later on, you know, vaccines, live vaccines, a live vaccine will do you harm. So anyway, that's how I got involved. And then a defector. You know, there's harm. Some people want to harm others, as you well know. A Russian defector came to the US and said, despite the fact that we've all agreed not to use or make smallpox virus, there was sort of a paramilitary group in Russia that was stockpiling smallpox virus. Even the government allegedly didn't know about this. So that's one reason why we still to this day have not destroyed our stock. There are only 2 laboratories that have admitted to holding variola virus. There were 76 at one time, and I lived in Geneva for 3 years toward the end of the program. And we spent a lot of time, effort, and arm twisting to get the number of labs from known 76 down to 2, Russia and the US. They could still do diagnostic work, but no research with the virus. So let's next talk something else that I've worked in. How are we doing? Good?
So far, so good.
Let's talk about a second disease, Guinea worm, a parasitic disease that is waterborne, and the cycle, natural cycle, goes from a person with the worm coming out of their body through a hole. The female always drills a hole to get out and lay her larva in water, which is picked up. See the little water flea, a mollusk at the bottom. And this water flea, it takes a year incubation period. The people who go and get the water then drink the infected mollusk, and then the 3rd and 4th stage larvae come out in the body. It takes a year for the adult female. And here are the countries with this horrific disease where there were millions, over 3.5 million known cases at that time. Again, in Africa, poorest of the poor, Indian subcontinent. Other places didn't have the problem, or it had gone decades, eons before. So this is 1986. There are 21 countries. Now Sudan has broken into South Sudan, 22. Next. And what were the strategies? The same as we mentioned before. Surveillance, finding the cases. Of course, not to be overwhelmed, to break it down village by village. Safe water, you could see. Tying the parasitic disease in with the safe water decade of the 1990s. Then giving patients service, covering their sores, these holes with antibiotics anyway, keeping them away from water, and getting the communities involved. How they get involved? By being sure that the sick patients didn't go back into the water. And then research and evaluation is absolutely essential for any program. That has been a little difficult, not just for Guinea worm, but a lot of public health people and a lot of funding agencies say, hey, you've got a golden bullet, a vaccine, a drug, an insecticide. Why do we have to invest in research? Don't do it. Don't buy that. You need research tied with operations in any program, because what? The unexpected will occur, as you have seen, and you'll see again. Next, and most important, you need leadership. Probably that's the most important. Not just the science, but you need people who will define the issue, the goal, speak about it, bring in people, delegate. And here's the leadership of the Guinea Worm program. Dr. M.I.D. Sharma from India, who ran the smallpox program, a brilliant scientist who had run the National Institute of Medical Research, and Dr. Nicole Grasset, who was chief of the smallpox program for the Southeast Asian, over 1.1 billion people. They started the Guinea Worm program, but mainly Dr. Sharma said, if we could do it with smallpox, we now inspired. And then at the Carter Center, we had Don Hopkins, a young, now MacArthur awardee, who's an eradicationist who had worked in Sierra Leone when I was in Guinea. And then Ernesto Tibin Ruiz from Puerto Rico, who had worked on schistosomiasis. They're the leaders of the program at the Carter Center. They both were at the CDC. Next. And here is using the strategy of safe water, community mobilization. Cases have dwindled down to, in 2000, mid-2000s, almost zero. We thought we were there. Again, the hypothesis, no non-human reservoir. Next. And here's an example of surveillance in Ghana, where I spent a fair amount of time evaluating the program. The country had reported 3,000 to 4,000 cases a year, but the village by village search, you found here almost 200,000 patients sick like this. Same here probably in the US, because a lot of people don't, not with Guinea worm, of course. If you want to find out what's going on, you have to be creative in doing social science and epidemiologic research. But here it is, in Ghana, 10 times the number of cases, or 20 times, or in some cases 100 times, were going on when you find out. Next. And here is an example of water. Anyone have seen people collecting water in these places? Yes, a lot of heads shaking. Who goes to collect water? Women, young girls and boys, occasionally a man, but women who do all the heavy lifting everywhere, period. And here is a joyous group of women because they now have wells, part of the program, pump protected wells, and they have safe water. Next. So we're merrily involved in the program, and we sent a team, because I'm now for a number of years been on the International Commission to certify countries free. We don't just accept a country's word. We have independent groups that go to these places, independent of WHO, of the country. And here, for 10 years, Chad had no cases. And they called WHO and said, please come and certify us. It's a big deal. And we sent a member of our commission, and they said, your surveillance is inadequate. Do all the things necessary. Collect specimens, do surveys, have a reward, do media, and all of a sudden they started finding human cases. Next, worse, not worse, but more challenging, we found dogs with Guinea worm. My goodness, what a shock this was to the eradication program. Okay, not to be defeated, we started more research. Next. And we found out, where are the dogs getting it? Is this related to humans or not? If we chain the dogs and treat the dog, there's no drug specific for Guinea worm. Are they going through the same cycle with these little copepods, these water fleas, drinking the water, same cycle? Are humans giving it to dogs, dogs giving it to humans? We have a conundrum here. So we have started research, high-powered research, really using stable radioisotopes to see what the dogs were eating, putting GIS markers on them, see where they were running. So, you know, even though horse and buggy stuff is how we do a lot of these programs, we're using a lot of modern science, using genetic approaches to the worms to see if they were the same, the animal as humans. And we found some baboons and some feral cats. So that we're in the middle of that now. And that's unexpected. Will we eliminate Guinea worm? Well, Jimmy Carter, who's very sick, as you may know from the paper, he's 95, says he wants the death of Guinea worm before he dies. Now, what's different about this program from smallpox is when Jimmy got involved, the political at the highest level, we just worked, if we could, with ministers of health, with ministers of finance a little bit, with international organizations. But Jimmy now went to presidents of countries, and he got several of them involved. Kofi Annan at the United Nations, and on and on. So this is different now with public health programs. We go to the highest level possible because health is development. Next. So now I want to talk about something I've worked on for 30 years. I am that old, yes. Next, this is the big one. A mosquito-borne, 5 minutes left? Okay, so we'll do this, and then we'll have questions, right? So we'll cover malaria. Mosquito-borne disease. Guess which male or female inoculates humans with malaria? Anyone? Female, right. This woman knows. It's always a female who does the disease. So, gives it to a human. This young child has parasites, billions of parasites running through her body. She can't go to school, do her activities. Mother has to stay home. And next, worst case, here's a vessel in the brain. They get clogged. Child has cerebral malaria. 20 to 30% will die. Next, even with treatment, if it gets that bad. Here's some electron microscopy of scanning of a red blood cell with the parasite inside. Anemia, malnutrition, chronic, and then because you've seen the parasites running through, you have poor learning, cognitive, executive function difficulty through an entire continent. And here you have a placenta on the right, teeming with parasites on the left, nice lacy, so that nutrition can transfer. And here's a newborn baby who has not received nutrition, and she or he has low birth weight. Once the birth weight gets below 2,000 grams, the child has maybe a 40 times chance of dying than a normal born baby. So we have a lot of programs. Let's continue on. Here is malaria in the world everywhere in the last century. So programs started with DDT spraying. That was a strategy. Next. That program failed. Everyone thought just spraying the world with DDT. Rachel Carson got involved. President Kennedy said, well, DDT might not be so good. But anyway, that didn't do the job. And this is the only text slide I want to really show you here, and then we'll have some questions, was that Africa was not included. That was unbelievable. That was a big mistake. Of course, this is colonial times. And the colonial powers, Britain, France, Portugal, Germany, we never had this colonial thing. We weren't involved. But we contributed $2 billion in the 50s to eradication, and the program failed in 1971. Here are the reasons. But there was no research program, I mentioned that, in innovation. Next. Until we got Bill and Melinda Gates. Bless them. Really, pitter patter for Bill and Melinda. They said, look, you guys are now frittering around the edges with some drugs, some mosquito nets. Let's set a goal out, an audacious goal. As you know, they do it everywhere in a lot of different things. But once they said they're not medical people at all, and then WHO and the US and the Europeans and others jumped in and said, sure, let's reinvigorate. Next. So the strategy then started with using drugs for treatment, good drugs, bed nets, which many of you have probably contributed to go to the net, bake sales in high school and the rest to prevent this terrible disease, and spraying with effective insecticides, and then focusing on the pregnant woman. So things are getting better now. Next. And here the north is free of malaria, but still the same hardcore areas exist. Vaccines, newer drugs, but what was unexpected? Next. Every drug we have thrown at malaria, the parasite has developed resistant to it. And insecticides, the insect has become resistant. So now, thanks to prescient investors, foundations, and organizations, and particularly governments, we have a great program of research. And I now work at National Institutes of Health, and we put a lot of money into looking at vaccines and drugs and other things in support using modern genetics, immunology, diagnostics to prevent this disease. So let's, maybe we'll stop here and go to questions. Next slide. Oh. Of all the papers I've published, this gets more attention than anything, I must say. The title of the paper is The Ears of the Hippopotamus, and I think I've introduced it by showing you some pictures of, if you don't go into the community, you know, and get cow dung on the bottom of your feet, you won't find out what's happening. So we did a number of surveys on where the people got ill and were treated. And for a few years when I started malaria, some of the senior scientists were showing pictures of icebergs. The iceberg effect. I said, that doesn't go for Africa. You know? They show an iceberg where people get sick. So bless Cherise Holloway, who worked with me at that time, spent a lot of time working on this slide, but you can see at the top where people go to the hospital, they don't have vehicles, you know. Treatment centers are far away, and there's no medicine. There was no medicine in any of these places. There may be a dispensary where something might be done. Of course, there's a traditional healer who are very popular, but don't do much. And then there's home treatment, which you have to talk to the families about if you give them whole drugs. So maybe I'll end with this slide, just to show you a few examples of diseases I've worked with where I've learned so much, mainly from the people at home treatment. Everything I've worked on has had unexpected surprises, all of them involving research that to be addressed. And that you educated people are going to do in whatever field you're in, the work for the future. And so the reason I'm still sitting is I do a lot of teaching. I have confidence in the next generation. So thank you very much. Yeah, question.
I was just wondering, when was the moment that you felt most inspired, either in your current work or leading up to getting into the field that you're in now?
That's an absolutely great question. I must say probably my first experience in Guinea at the end of 2 years. So I was coming back to be a treating doctor. When I said, here, this horrible disease in 2 years in a country of 4 million, my patient is now a country instead of an individual. And if we could do this in communities, so I was now inspired to learn more about infectious diseases. That's where my training went, and tropical medicine. So I was like, and then a lot of the people I worked with were great leaders who showed me, you know, demonstrated in their work. But I would say that's how I explain it, that my patients are now countries. And I saw it in action. And of course, the people I work with, they get the job done. We had in smallpox 200,000 people going door to door, really. So they were inspired. Yes?
What steps would you recommend for an undergraduate that's interested in eventually pursuing a career in global medicine?
So I get this question all the time. I say, develop some skills, whatever they are. For undergraduates, I've had undergraduates work with me in the study that I told you about. Well, I didn't tell you the details about some doing surveys of poor quality drugs. Undergraduate jumped into that, found literature reviews. Going overseas, important to see if you like this or not. I'm a big fan of the Peace Corps. I'll tell you that. You will find out more about yourself than anything you contribute. We have Peace Corps in the family. I took care of Peace Corps volunteers as a doctor in these places. I know a lot about this grassroots thing. But you gain some skills where you'll be of benefit rather than a burden. Because you get, I mean, the people living in these places know more about how things operate than you do. We have, as I said, resources, networks, advice, bringing modern science. So I would say, get some skills, have a plan, and follow this dictum here. He who would do good must do it in minute particular. General good, which so many people, I want to do good, I want to go overseas and help, is the plea of the scoundrel, hypocrite, and flatterer. For art and science cannot, and public health, I'll tell you, cannot not exist but in minutely organized particulars. My mantra from this is break it down, bird by bird. Anyone read Anne Lamott's books? Huh? Yeah, she wrote one, bird by bird. one thing at a time and do it right. So for everything in life, just try and make a plan and get the skills. And now, domestic health, our problems here, I don't want to say they're not important. They're part of global health, aren't they? So we have so many issues here. Question? Yes.
What is your most effective response to like the anti-vax movement, or when you're communicating with people who?
Okay, great question. So such an important problem for a lot of things. The vaccines are the most cost-effective means of public health. My response, I'm an evidence-based guy. Some people just can't be convinced. It's a question of some people thinking that because we have reduced the incidence and eradicated some, they feel that there's no risk to them. They don't have the community understanding. I don't know what works best, but certainly posters and TV shots are not the best, but the epidemic you've had of measles here, right? I don't know if there have been outbreaks on campus, but there have been in other places. Everyone runs, probably meningitis also, everyone runs, or the school requires that they get. I'd say young people convincing others. But here you have celebrities, Jenny McCarthy, Robert Kennedy Jr., several other well-known people have, no matter what you say, they have what's called an E-Day fix. You can't convince them otherwise. So you just show them how vaccination has helped communities just eliminate these problems so that they're not an issue. So I don't have the answer. There are now scientists looking into why this happens, what we can do, but it's that's unexpected. That's a great question, because in vaccines, particularly for polio, and even in the poor countries, outbreaks in northern Nigeria and in the last refuge of wild polio virus in Pakistan, Afghanistan, some of the vaccinators, women vaccinators, because the women are in PERDA, have been killed by not the anti-vaccinated, but thinking they're, being contaminated with the children, with HIV, with birth control, or with other things. So, I don't have the real answer. Maybe young people will come up with something that is more effective than old white-haired men telling them what to do. That doesn't work anymore, right?
Are there any last question or two? Any other hands, just so we know, maybe we can take? Yeah, you definitely, but I'm just trying to see if anybody else. Okay, floor is yours.
Are there any measures in the government to protect from bioterrorism towards ourselves? Because I know the government's used it against people in the past before.
Well, the government is very active now, and there's an Office of Civilian Protection, not just from bioterrorism, but from nuclear and biochemical stuff. And yeah, they have drills, and it's not just the government, it's state and local hospitals all have plans. I mean, recall a few years ago, I got a section here on Ebola, which is interesting, but when that hit, we're all worried about that being imported into the country, so that all the hospitals, geared up for what they would do if some infection came in. And, the big one is influenza. I hope you know about. I hope everyone here is vaccinated against influenza. Okay? A lot of heads shaking. A lot of heads not shaking, but get it. So that's a great question. And yes, there's a lot going on, but not enough, because we're a mosaic of individuals and communities and free thinkers and others who are worried about the government. But yes, we are here to protect you. So be part of it. It's noble work, important. Yes.
Hi, John. Thank you. That was really interesting. I just wondered if you could say something about the politics of doing this work and how about, but there's politics at the global level and the national and the local levels where you're working, and I just wondered if you could say something about how you dealt with that across your career.
Well, that's a very important question in relation to how are some things chosen for focus and others. Why aren't they all packaged together? And are some packages more effective? Again, as I said, burden is important, being sure the epidemiology, defining what the problems are and convincing people, and then doing the economics. In this day and age, the funders and the politicians are really interested. While they have, many of them are humanitarian, have big hearts, they want to know what we will gain from this. Has anyone here heard of disability adjusted life years? There we go. Not enough. You should know about that. So if a young person gets this malaria cerebral and lives an entire life with this impairment, that is different than an old person having a heart attack or cancer and living 2 or 3 years. So the disability to the society, I mean, sometimes you pull back when you think of how we're parsing the value of a life, but that's how the economists and our funders are asking. So that's, and I've co-authored a book on disease control priorities, and I've lived and talked with economists who who don't speak English, by the way. So when you say, what can you do? You might, I mean, that's a field that's open, health and economics. Health and inequalities. When we have a great new burgeoning institute of inequality. So convincing people using quantitative data is important. Breaking it down and doing due diligence research using modern techniques. So I'd say that's most important. But politicians have their own favorite themes. Family member may have had some problem and come to NIH, say, how come you're not working on disease X, Y, Z? And then we'll work on it if the money comes with it. Okay, great question.
So will you all join me in thanking Dr. Breman?